basically what happens is you'll have, for example, a ventricular septal defect, which is a hole in the septum between the right and the left ventricle. And what happens is a high pressure left side gets into the right side, and when it does, it starts driving up the pressure on the right side, causing obstructive disease in the arterioles. Tetralogy of Fallot, the VSD with the overriding aortas, and others. Sometimes the primus or the truncus can sometimes give you that as well. But more importantly is keep in mind that anything that's coming from the left side of the heart to the right side of the heart can drive the blood pressure up and of course start the whole process in the pulmonary arteries. So Eisenmenger syndrome. I'll give you a pop quiz at the end of this presentation about that. Risk factors. We're about halfway through now. The risk factors, well, obviously, if you come from a family that has this particular problem, it can be devastating. And quite oftentimes, if you know that, it's wise to get genetic counseling, get genetic testing, especially if you're a young female, and so forth. The secondary causes need to be diagnosed. So anytime you have these patients that I just mentioned in terms of the causes, those are the patients that you do need to double check with reference to getting a good reading. Complications. The one I mentioned before was the cor pulmonale, the right ventricular failure, which leads to a backup of fluid on the right side of the heart, affecting the whole body. Is the most common problem of pulmonary hypertension, and we treat it accordingly. Blood clots, big problem in this side. The treatment, and there will be a second article that I'm going to give you about these new anticoagulants. There's a lot of problems with them. Here in this institution, we've actually had 4 patients present with CNS bleeds. You see some of the TV commercials, you think you need to take this with your post-toasties in the morning. It's very dangerous. And the problem with it is that there's no reversibility. So that's why many cardiologists are staying with Coumadin, because I can reverse Coumadin. It's easy to reverse Coumadin. Or heparin in an acute phase for a blood clot, pulmonary blood clot. It's easy to reverse if we give too much heparin. Not so with these other new anticoagulants. Abnormal rhythms, atrial fibrillation, and other cardiac arrhythmias can lead to pulmonary hypertension as a complication. And finally, bleeding. You can actually have pulmonary hypertension so bad that a patient can start spitting up blood. And I'm sure those of you in the respiratory field have seen this. And you see hemoptysis. It's not just the left heart failure. It can be obviously pulmonary hypertension causing your hemoptysis. And for those of you who are taking your exams, never forget Goodpasture syndrome. Okay, let's talk about tests. Tests and making the diagnosis. Like I mentioned, I can't exactly go in and take a blood pressure cuff and take a blood pressure in your lungs. But there's a lot of things we can do, such as a good chest x-ray, which shows me whether or not the cardiac silhouette is enlarged, showing my ventricular failure. The easiest thing to do, of course, is an echocardiogram, which registers your TR. But as one is my echo tech in my office, he has actually shown me some of those cases where the TR jet is hard to find. And you have to take several different readings, get the best reading, and then of course the Newley's equation with the size of your inferior vena cava, and it's 0, 5, 10, and you add it together, and that should be your blood pressure, systolic pulmonary blood pressure of what, maybe 25? Anything greater than that is pulmonary hypertension. You can also do a transesophageal echocardiogram to get a good TR evaluation. Lastly, you can actually do a right heart cath. A lot of us in the early days when we used those big catheters that were not quite as flexible, we would come in. actually had one attending, Dr. Everett Price, who tried to do one on a kid, and unfortunately the patient expired. Because it was so stressful to the pulmonary side that any little obstruction in any one of the arteries was ready to cause VFib. So it's a dangerous procedure to do pulmonary hypertension. Now with the new catheters, it's a lot safer, but it's not without its risk. You can also do your pulmonary function studies, your perfusion studies, incorporated with your ventilation scans to show your defects, whether or not you have clots. CT scans of the lungs can help, as well as magnetic resonance imaging. Finally, you need to know there are some physicians that will ask for an open lung biopsy. They'll ask for an open lung biopsy because they really want to know, not just from reading from the electron cath, do I have an obstruction process going on with pulmonary arteries? So that's also available to you. The genetic testings are available now. How many of you have done your own swabs and sent it off to, what is it, Heritage or Ancestry.com, one of those, just to find out, you know, did my ancestors come from Spain? I had one of my cousins said, well, he came back 20% Russian. Ah, somebody jumped the ship. So now there's a certain other thing you need to know about the classification of pulmonary hypertension. Class 1 would be the diagnosis of pulmonary hypertension, but you have no symptoms. Class 2 is that you have symptoms with normal activity. In other words, I'm just going to walk to the door and I suddenly start having shortness of breath. That would be a level 2. If I try to run over there and I get short of breath, then I've got a level 3. And finally, when I have symptoms at rest, then I'm clearly a level 4. So that's an easy way of kind of figuring out how bad the disease is. Treatments. Unfortunately, there's not a lot available for our patients. We try to give them the very best we can. In the old days, back when the dinosaurs walked this planet, we used to put a swan gas catheter into the pulmonary artery and give the patient either IV hydralazine or some sort of vasodilator and see if the blood pressure would drop to 25 or not, and watch their symptoms also. Nowadays we have newer forms of vasodilators. One is Flolan. Anybody have any experience with Flolan? Yeah, and does the patient carry their little thing and continuously inject it kind of thing? It's almost like an insulin pump kind of thing. Right. And any side effects? Did the patients complain of any side effects at all? You have to give high doses before you get it, but there's some patients that are very, very sensitive. Usually it's jaw pain, nausea, diarrhea, leg cramps, pain, Flolan. The other particular area is endothelium receptor antagonist. As I told you, whatever genetic predisposition or disease process that's causing the obstruction, you can give an antagonist to that to keep those pulmonary arteries as wide as possible. Okay, so endothelial antagonists are very useful. Sildenafil, this is the, sildenafil. This was actually being studied as an antihypertensive on the left side, and all of a sudden all the men started migrating over there. Why? Side effects, obviously. Right? It's Viagra. And so I want to be in that group over there. It was like, I want to be over there.